Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Here to the right, we have a representation of the various waveforms of valvular anomalies, such as aortic stenosis, mitral regurgitation, etc. I'm sure you've heard these terms, you know them well. This is going to provide a review of the valvular disorders pathology. This is covered in your book, Medical School Pathology and Step 1 Review. Utilize it. It has everything in it that you need to succeed on Step 1. It's even good for your coursework. And it serves as a foundation for your medical practice. So make sure you get all this stuff now. Know it well because it comes up again and again and again. It never stops. So if your foundation is strong, you can build mansions. You can build towers, skyscrapers of knowledge. But it starts now. Valvular disorders. Now, like we learned in anatomy, in normal circumstances, the heart has 4 valves: the aortic valve, pulmonic valve, tricuspid, and the mitral valve. Now, the cardiac valves ideally prevent backflow. That's what valves do. Prevent the flow from going in the wrong direction. Valvular lesions generally result in either stenosis or regurgitation. Various valvular disorders can even show up on an electrocardiogram. This one, for instance, shows a left ventricular hypertrophy, which is associated with aortic stenosis, because the left ventricle has to squeeze harder, squeeze more, causing those muscle fibers to hypertrophy. Here we have a cartoon representation of the various valves. Note that this diagram shows the valves of the heart, of a normal heart, okay? With regards to specific pathologies, let's start with acute rheumatic fever. It's highly tested. You will see this. Acute rheumatic fever is caused by group A beta hemolytic streptococci. Children are susceptible to the systemic consequences of streptococcal pharyngitis, often known as strep throat. And this is usually 2 to 3 weeks after an episode. Acute rheumatic fever is caused by molecular mimicry due to a bacterial M protein that resembles proteins in human tissue. So what's happening is your immune cells recognize this foreign pathogen that's causing acute rheumatic fever, and it produces antibodies and molecules that try to fight it off. But those things that are produced are so similar to things that are already present in your body that the immune response starts affecting your own body. Isn't that crazy? I don't like you, acute rheumatic fever. Not one bit. The diagnosis of acute rheumatic fever is based on the Jones criteria, which consists of major and minor criteria. Major criteria of Jones criteria for diagnosing acute rheumatic fever include JONES, joints, heart, nodules, erythema marginatum, and Sydenham chorea. Remember that the O looks like a heart for Jones. Specifically, how are the joints affected? Well, arthritis, they get swollen, they become warm. How's the heart affected? All the itises, right? Myocarditis, endocarditis, cardiac valve issues, pericarditis. Now, what about the skin? Future dermatologists, keep this on your differential. The skin from a patient with acute rheumatic fever may actually show skin nodules, quite often on the extensor surfaces. They might even have erythema marginatum, which is a specific type of rash. And regarding the S of Jones, that's Sydenham chorea, which is an abnormal movement disorder. So future neurologists, listen up. Have this on your differential when a child is reported as shaking or spazzing out, right? This is not necessarily an epileptic seizure, right? Hold on, giving benzodiazepines and valproic acid. No need for lamotrigine yet. They might just have Sydenham chorea. Now, what are the minor criteria of Jones criteria for diagnosing acute rheumatic fever? Well, it's peace. Something that my ex-girlfriend didn't give me. Peace. Previous history of rheumatic fever, echocardiogram, arthralgias, CRP is elevated, and an elevated erythrocyte sedimentation rate, as well as an elevated temperature, hence fever. Okay? Prior evidence of a group A beta hemolytic streptococcus infection aids with the diagnosis as well. Specific labs that will aid in the diagnosis of acute rheumatic fever include ones that you're very familiar with at this point, right? You know these. Anti-streptolysin O titer, also known as a ASO titer, as well as anti-DNase B titer, right? Now, the diagnosis of acute rheumatic fever require 2 major and 1 minor features being present, or 1 major and 2 minor features being present. The mitral valve is the most affected cardiac valve regarding acute rheumatic fever. There will be these small vegetations that accrue on the valve along the lines of the closure that result in mitral regurgitation. Regarding histology, future pathologists, the histology of acute rheumatic fever shows reactive histiocytes with slender, wavy nuclei, which are known as Anichkow cells, as well as Ashtoff bodies, gigantic cells, and fibrinoid material. The most frequent cause of death in acute rheumatic fever is myocarditis. Erythema marginatum, that skin rash associated with acute rheumatic fever, is a non-pruritic, it doesn't itch, annular rash with erythematous borders that often affects the trunk and limbs. Erythema marginatum. And what will you hear in a patient that has pericarditis when you pull out your stethoscope? Right? You'll hear a friction rub. And they will also present with chest pain. And keep in mind that Sydenham chorea is the rapid, involuntary muscle movements associated with acute rheumatic fever. The acute attack normally goes away, but it could turn into a persistent case of rheumatic heart disease. Relapse of the acute phase and increased risk for chronic disease are brought on by repeated exposure to group A hemolytic streptococci. Here we have a picture of a teenager's mouth. Note the exudate in the back of their throat. It turned out that they were culture positive for streptococcal pharyngitis. And here we have a cardiac biopsy with an and with an Aschoff body in the center. Now, how do we know that this is a cardiac biopsy, by the way? Right? You know about the various muscles, right? You know smooth muscle, right? You know skeletal muscle, and you know cardiac muscle. And you know that they are somewhat distinct in their histologic appearance, right? Smooth muscles, unlike what we see here, are typically spindle-shaped with the central nucleus, and they lack the striations, right? But if you see striations, you can think cardiac muscle or skeletal muscle. Now, how do you differentiate those? Well, the nuclei of cardiac muscle typically will be what? Multinucleated, right? Whereas the nuclei of skeletal muscles are usually singular and pushed off to the side. Also, it's important to remember that the histology for skeletal muscles, they have these specialized junctions that allow synchrony for the adjacent myocardiocytes, right? So that they contract in unison for a nice, steady boom, 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 right? For blood flow. Do you know what those intercalated discs are called? Trick question. They're called intercalated discs. But you already know that. Now, let's talk about chronic rheumatic heart disease. Chronic rheumatic heart disease develops when rheumatic fever-related valve scarring leads to stenosis with the classic fish mouth appearance. Here we have a histologic representation of that with various immunohistochemistry. In chronic rheumatic heart disease, the chordae tendineae and cusps thicken as a result of the mitral valve being involved almost 100% of the time. Quite often, the aortic valve is involved, which results in the commissures fusing together. Other valves are less commonly involved, and complications include infectious endocarditis. Here we have a picture of a heart, likely from an autopsy specimen or a transplant specimen. Either way, this is a massive heart that's been removed from a patient or cadaver. Either way, the gross pathology is showing a left ventricle that has been cut open to display that severe thickening of the mitral valve, as well as thickened chordae tendineae and a hypertrophied left ventricular myocardium. In regards to this image, it's highlighting the pathophysiology of rheumatic. Speaking, I can do that. This is highlighting the pathophysiology of rheumatic heart disease, okay? Take note in the top left where the initial insult of strep infection occurred, and all this complex downstream effects through the mimicry, through the autoimmune impact. It also causes all sorts of issues, right? The downstream effects include congestive heart failure, arrhythmias, etc. So we want to stave this off. Now let's talk a bit about aortic stenosis. Aortic stenosis occurs when the aortic valve orifice narrows, gets smaller, stenotic. And here we can see an image of gross pathology from a patient that had rheumatic heart disease showing aortic stenosis. Note, this is going to show up. Aortic stenosis is typically brought on by fibrosis from calcification from wear and tear. And note, patients with bicuspid aortic valves are at increased risk. That will definitely show up. Aortic stenosis usually affects individuals above 60 years old. Why, Dr. Wheeler? Well, I'll tell you. It's because these individuals had time to live and accrue more stenotic calcification on their aortic valves. And it gets worse over time, hence why it's elderly people. Now, risk factors for developing aortic stenosis include having a bicuspid aortic valve or rheumatic heart valve disease. Aortic stenosis typically causes a crescendo, decrescendo murmur after a systolic ejection click. That shows up frequently as well. Aortic stenosis, don't say I didn't tell you this, aortic stenosis causes a crescendo, decrescendo murmur after a systolic ejection click. Got it? Now, complications of aortic stenosis include concentric left ventricular hypertrophy, right? Angina, syncope, potentially cardiac failure, and even microangiopathic hemolytic anemia. And you already know that, right? Because we went over this in another lecture, how that microangiopathic hemolytic anemia occurs. As a quick review, you have shearing of red blood cells that go through those valves. And when those red blood cells are lysed, guess what? Diminished red blood cell counts. Hemolytic anemia. The treatment of aortic stenosis is valve replacement. And thank God, or whatever deity you believe in, the universe, that surgeons exist to do this. Maybe you'll be a surgeon one day. Regarding aortic stenosis, here is a cartoon showing a general representation of narrowing of the aortic valve. And here is a color scanning electron micrograph showing cardiovascular calcification. Note the orange is calcium phosphate particles, and the green is the cellular extracellular matrix. Let's talk a bit about aortic regurgitation. Aortic regurgitation is the backflow of blood from the aorta into the left ventricle. Whoa, it's not really supposed to go that way, but with aortic regurgitation, it does. Aortic regurgitation is the backflow of blood from the aorta into the left ventricle, and this occurs during diastole, caused by aortic root dilation or valve damage. Aortic regurgitation is the most common cause of isolated aortic root dilation. Clinical features of aortic regurgitation include an early blowing diastolic murmur and hyperdynamic circulation due to increased pulse pressure. The difference between systolic and diastolic pressures is known as the pulse pressure. Diastolic pressure decreases as a result of regurgitation, but systolic pressure increases as a result of increased stroke volume. The increased pulse pressure associated with aortic regurgitation is characterized by some key physical findings, which include water hammer pulse, pulsating nail bed, known as the Quincke pulse, as well as head bobbing, right? So you might see those on a clinical vignette setting you up for aortic regurgitation. Note that aortic regurgitation generally results in left ventricle dilation and eccentric hypertrophy due to volume overload. Treatment of aortic regurgitation is valve replacement once the left ventricle dysfunction develops. And here we have a cartoon representation showing aortic regurgitation. Note the arrow pointing flow from the aorta into the left ventricle. And here is a histologic sample showing myxomatous degeneration, which is a potential cause of aortic regurgitation. Now here we have a cartoon comparing aortic regurgitation to aortic stenosis. Make sure you can see the difference. Now let's move on and talk about another highly asked about issue: mitral valve prolapse. Now, mitral valve prolapse is the ballooning of the mitral valve into the left atrium during systole. Mitral valve prolapse is present in about 2 to 3% of American adults due to myxoid degeneration of the mitral valve, which causes it to become floppy, kind of like a dog's ears, right? Well, some dogs' ears. The cause of mitral valve prolapse is unknown. However, it is associated with myxoid degeneration. Mitral valve prolapse is associated with two key syndromes that you know in depth, right? You know about Marfan syndrome, and you know about Ehlers-Danlos syndrome, right? Of those two, who tends to be more tall? Marfan's, right? Regarding mitral valve prolapse, it typically presents with an incidental mid-systolic click followed by a regurgitation murmur that is usually asymptomatic. If you have a patient with mitral valve prolapse, squatting usually increases the click and murmur volume of the mitral valve prolapse due to the increased systemic resistance and slows left ventricular emptying. Complications of mitral valve prolapse include infectious endocarditis, arrhythmia, and severe mitral valve regurgitation. Treatment of aortic regurgitation, by the way, is valve replacement, as well as mitral valve prolapse issues. Regarding mitral valve prolapse, we have a cartoon showing what happens in the various cycles. For example, during late systole, the mitral valve leaflets come back into the left atrium. They cove back into there. And this diagram shows that the leaflets lying behind an imaginary line drawn between the posterior aortic root and the atrioventricular groove, right? You see that? Here, we have a radiologic representation showing the 4-chamber heart on the left, and then on the right, mitral valve prolapse. And if you can see that, you need to be a cardiologist. Start working on that. I think the route's through internal medicine. Good luck. Now, regarding mitral valve prolapse, Here's a diagram of an inverted heart. And note the concavity of the leaflets, demonstrating what it looks like for a valve to be prolapsed. And here's another cartoon representation of mitral valve prolapse. Note the blood abnormally flowing from the left ventricle back into the left atrium. And here's a transesophageal echocardiogram showing mitral valve prolapse. Note regarding mitral regurgitation. This typically occurs when blood flows from the left ventricle into the left atrium during systole and is mainly caused by mitral valve prolapse. Regarding mitral regurgitation, some common causes that you should definitely know include acute rheumatic heart disease or papillary muscle rupture following a myocardial infarction, right? Left ventricle dilation and infective endocarditis. Clinical features of mitral regurgitation include a holosystolic blowing murmur that becomes louder with squatting due to the higher systemic resistance. There's also decreased left ventricular emptying and greater return to the left atrium on expiration. Keep in mind that mitral regurgitation may cause volume overload as well as left-sided cardiac failure. And here we have imaging showing a severe mitral regurgitation. And here we have a comparison between mitral valve regurgitation and mitral valve stenosis. Here's another cartoon showing mitral regurgitation. You see the way that the blood's flowing? Do you see which way that the valves are pointing? And again, mitral regurgitation. And note that the colored cloud symbolizes the return blood flow. 1 is the left ventricle and 2 is the left atrium. Let's talk a bit about mitral stenosis. Mitral stenosis is the narrowing of the mitral valve orifice. Mitral stenosis is associated with persistent rheumatic valve disease. And clinical findings of mitral stenosis include an opening snap, followed by a diastolic rumbling, volume overload that causes the left atrium to enlarge, and pulmonary congestion with edema and alveolar hemorrhage. It also may present with pulmonary hypertension and possibly right-sided heart failure. Mitral stenosis may cause atrial fibrillation with associated risk for mural thrombi, right? Because with that fibrillation, you get non-laminar flow, and that causes potential clots to form and then build up where the flow is disrupted, leading to a mural thrombi. And with that, you made it. Another lecture in the books. You know so much. Give yourself a pat on the back. You're really doing it. You got this. I'm proud of you. Your family's proud of you. Your mentors are proud of you. Your friends are proud of you. Keep learning. Keep growing. And I'll see you on the next one. Bye-bye.